Hello, hello, hello. Good morning, students. Good morning. Welcome, all of you. Can all of you hear me? Can all of you see me? Uh, from where we are streaming, there would be a lag of around say 10 seconds. So just wanted to confirm whether are we live now. Yes, I think just we'll get a confirmation. Can all of you hear me? Can all of you see me? Okay, so welcome all of you to our class, which is yeah good. Okay, yeah. So we are live now. Thank you for the confirmation. And this is some of the important MCQs, high yield MCQs for the NEET PG. What we are going to discuss. Just a second. Yes, so I think yes, all of you, yes, okay, good, excellent. So we are live now. I have got a confirmation. Thank you very much. And yes, so I think yes, all of you, yes, okay, good, excellent. So we are live now. Yes, so welcome all of you. Just a couple of important announcements before we begin our session. So the Unacademy subscription, all of you, there's some special offers. But before that, this is the calendar for the month of March, where you have got lots of free test calendars. Please take the part in this test. Okay, FMG grand test. Okay, then you have the NEET PG test, educator special curated test, mixed bag previous year's question that is happening, and a YouTube session and image based mix based also in the upcoming weeks. Okay, so and on March 20th there is the combat, okay, based on your cardiovascular system, and there are lots of scholarships which you will get, and the code is mentor, mentor, in case you need to participate, all of you. So 100% scholarship, rank 2 also 100% scholarship, and lots of things. So all of you, please participate 20th March at 12 p.m. for the combat. Okay, plus subscription, what all you get live classes, recorded classes, best teachers, anytime, anywhere, question bank, device of your choice, and of course question bank and test series also. Iconic subscription also available. The promo code used to get the discount is mentor. And all of you, this is very very important. Today is 16th, so 14, 15, 16th, okay, extra discount. Normally you get 10% discount, this extra 10% discount. So please use the code mentor, mentor, and try to enroll today, those who haven't enrolled, because this is only for today, 14th to 16th March. So today is the last day. So anybody waiting to enroll, please join soon. Depending on your requirement, you can go for 6 months, 1 year, 2 year subscription. Excellent results in FMG as well as NEET PG examination. You all know the features: live classes, raise the hand, never miss a lecture, lecture notes, and anytime, anywhere. Okay, and this is the all educator batch also, for which will be a part, and various other batches are going to start for the different examination. So depending on your requirement, 6 months, 9 months, 12 months, 18 months subscription available. This is for this with 20% discount, which is there today and yesterday and today. So today is the last day, so quickly get in touch and get the subscription done. Okay, now coming on to our MCQ discussion for the NEET PG examination. I want all of you to answer the question. Right, wrong does not matter. Okay, so all of you, starting with the first question. Yes, anybody? Yeah, all of you, Shri Rathod, Ibiza, Christina, yes, hello, yeah. Okay, so we have got, what do we have got? We have a lady who had a PPH. We have a lady who had developed PPH, and following PPH there was a hypotensive shock, and she has developed Sheehan syndrome. Can anybody tell me what is, first of all, Sheehan syndrome? Yes, anybody? What is Sheehan syndrome? Okay, Rajdeep Saha is saying option C. Okay, Rupesh is saying option C. Okay, but first, all of you, please, and which of the following, now she wants to have babies again, so ovulation I need to induce. So which of the thing? So first of all, anyway, remember that estrogen is never used for ovulation induction. Okay, now all these are the other drugs which are available for ovulation induction. Very good, Rajdeep. The important point is that when the patient has Sheehan syndrome, it is basically postpartum pituitary necrosis. So basically basically what we should know is that the pituitary is not functioning. Are you understanding? Yes, very good. Are you understanding the main problem with the patient? Because then only you will understand the question. Now can anybody tell me what does clomiphene citrate do? Clomiphene citrate is what kind of a drug? Clomiphene citrate is a selective estrogen, as selective estrogen receptor modulator. It gives patient, yes, Shastri, be very good. Okay, so it's a SERM. Basically it gives the body a feeling of anti-estrogenic feeling. That body feels that in the body there is no estrogen, and that causes the pituitary, that will cause the pituitary to secrete more FSH, which is normally what we would want, that sir, for follicle growth we want FSH to come pituitary. But here, will this work? Sorry sir, clomiphene citrate will not work because pituitary itself is damaged. Do you understand? So that is ruled out. Okay, yes, you used in PCOD also, that's okay. Clomiphene citrate. Similarly, letrozole is also a anti-estrogenic drug, and that will again cause the pituitary gland to secrete more FSH. Do you understand? So option D and option E are out. Why option D and option E are out? Because sir, clomiphene citrate as well as letrozole causes the pituitary gland, stimulates the pituitary gland to secrete more FSH. That would work in patients whose pituitary is normally functioning. In the question we have postpartum pituitary necrosis, so both these options are not going to work because pituitary is damaged. Yes or no? Thumbs up. Do you understand this? So this will not work, this will not work. And similarly, those in the starting, many of you said pulsatile GnRH, will this work? No, not again in this case. Why GnRH will not work? GnRH you would give to a patient who's because GnRH comes from hypothalamus. Yes or no? GnRH is coming from where? From hypothalamus. But hypothalamus will work where? So GnRH will work on the pituitary gland to secrete more FSH. Is it understood to all of you? But again, pituitary is not functioning in this case, and therefore this is also out. I basically will require hormones which can directly replace the pituitary secretion. So what are the pituitary secretions? Basically FSH. So either a recombinant FSH is available, which injections you can give, recombinant FSH injections are available, or anybody, what is HMG? HMG is the answer over here. What is HMG? Human menopausal gonadotropin. Okay, human, I'm writing human, H stands for human, MP is menopausal gonadotropin, which is nothing. How do we get it? Anybody? How do we get HMG? HMG is from the urine of the postmenopausal lady. Is it understood to all of you? Why? Because when a lady reaches menopause, when anybody reaches menopause, which hormone is very, very high? Sir, in menopausal state, FSH is going to be very, very high. And that FSH comes in the urine. So from the urine of the menopausal lady, what hormone I get is HMG, which is nothing but mainly FSH, and it also contains LH, because at menopause, when anybody reaches menopause, when females reach menopause, FSH and LH are very, very high. Is this understood to all of you? FSH is for the follicular growth, LH is for final maturation and successful ovulation. Okay, is it understood to all of you? So here we would require, in this patient who has had a pituitary necrosis or a Sheehan syndrome, we would require HMG injection or a recombinant FSH. Is this understood to all of you? This is a very, very important MCQ, concept based MCQ, which if you know the concept, you know things very easily. Okay, sir, pituitary gland is gone. So option C, option D, option E will not work because all of them are pituitary dependent. I would want to replace my pituitary gland and directly give the pituitary secretion. So what is pituitary secretion? FSH, because pituitary is not there. So HMG injections or recombinant FSH will help her with ovulation induction. And anybody, just for your reference and knowledge, you have discussed it in the actual class also, once I give this medicines, anybody, what do I do to confirm whether these medicines are working or not? How do we check the response to this medicine? Any idea? How do we check the response to this medicine? What we do is we do a ultrasonography called as follicular study. Yes or no? Do you know this follicular study? It's a series of ultrasonography which we do so that I know, okay sir, initially when I start the injection, the follicle is small, then the follicle is growing, then the follicle is growing, then the follicle is growing. Yes or no? Because with my ovulation induction, the follicle should keep on growing, growing, growing. Is this understood to all of you? Inside the follicle is the egg. Egg is microscopic, which we can't see, but follicle can be seen on USG. So it is called as a follicular study, which is nothing but a ultrasonography, which is preferably a transvaginal sonography. Okay, so very important. Sheehan syndrome, MCQ, postpartum pituitary necrosis, FSH secretion or HMG. Yes, again going on to the next question, we have a hypertensive patient who complains of decreased fetal movements. Okay, so what do you do when there's decreased fetal movements? Okay, she is 37 weeks of gestation, baby weight 2.2. Concerns regarding the placental reserve for oxygenation of the fetus. Which of the following test helps you assess? So basically, but this is the second question, Srishti. This is now the second question. The first question was the postpartum pituitary necrosis, which is just finished. We have moved on to the second question. Okay. Yes. Anybody? So which of the following will tell me that the baby is okay? The placental reserves and oxygen status for the fetus are okay out of the following A, B, C, D. Is it clear to all of you? Yes. So anybody, let me go one by one. Alpha fetoprotein in the mother. Alpha fetoprotein in the mother. Yes, very good. Shrishti, Ibiza, Abhi, Rajdeep or Dr. Christina, all of you correct. Excellent. Alpha fetoprotein in the mother is a marker for neural tube defect. If the alpha fetoprotein is elevated, it has nothing to do with the fetal oxygen reserve and placental function. Basically, here I want to see what is the meaning of this. I would want to do a test for fetal well-being. Which of the following basically fetal well-being? Whether the baby inside the mother is okay, getting adequate oxygen. We want to do first fetal well-being test. So basically to detect whether the baby is getting adequate oxygen or there is any fetal hypoxia. Is this understood to all of you? L/S ratio is not with the oxygen status. L/S ratio in the amniotic fluid is for what? Anybody? L/S ratio in the amniotic fluid is what? It is for RDS. It is for basically lung maturity. We know that if the L/S ratio is more than 2:1, more than 2:1, L/S ratio, if it's more than 2:1, the baby lungs are mature and the baby will not develop RDS. Very good, surfactant. Very good, Shrishti and Shri Rathod. Yes, perfectly correct. And similarly, fetal growth curve on USG, what you do, that how is the baby putting on weight, that is as your for the baby weight. Okay, fetal growth is mainly for the baby weight, whether the baby is growing optimally or not. And basically IUGR, if the growth is not proper, that is IUGR, but that's not immediately with the fetal oxygen. Anybody, what is the answer over here? BPP, biophysical profile. Anybody? All of you should know what are the 5 components of biophysical profile, and it's called as whose name? Anybody? BPP is whose criteria? BPP is also called as Manning's score or Manning's criteria. Yes or no? Is this understood to all of you? And what are the 5 things? Sir, NST is a part of it. NST, non-stress test, is done and other things are done. Fetal tone, very good. Fetal body movements. Okay, what else? Fetal breathing movements. Okay, fetal breathing movements. And what else? The last one is the amniotic fluid volume or the amniotic pocket around the baby. Okay, at least a pocket or amniotic fluid, basically amniotic volume के लिए करते हैं, one single pocket at least 2 centimeter. Okay, so this thing tells me that if the NST is normal, tone, baby movements, breathing all are normal, then the fetus is getting adequate oxygen and there is no fetal distress. Okay. Yes, very good, all of you. Yeah, AFI is all 4 quadrant, Dr. Christina. AFI is all 4 quadrant, which is a separate thing. In biophysical, we only look at one of the quadrants. Okay, there's slight technical difference. Okay, and all of you, if I ask you, all of you, just tell me in the answer the maximum score. Anybody? Maximum score of BPP is how much? 7, 9, 11, 100, 1000, 10, 20. What is the maximum score of BPP possible for any of the patient? Very good. So sir, it cannot be 7, 9, 11, 10, 1020. It is 10. Why? Because sir, there are totally 5 components and each component is given a scoring of 2 or 0. What do I mean? That means sir, NST normal, give 2 points. If NST non-reactive, I give 0. Fetal tone present, I give 2. If not, I give 0. Movements present, 2. Breathing present, 2. Liker pocket normal, 2. So all of you can see basically 10 by 10 tells me baby is absolutely good. Takatak, baby is fine. 10 by 10 score is good. And as the score is becoming lesser, there is problem with the baby. So 8 by 10, slight problem. 6 by 10, more problem. 4 by 10, severe problem. You need to basically get the baby out. So this is how basically for placental reserve and oxygenation of the fetus, and when there is decreased fetal movements, we are supposed to do NST and BPP. So yes, 8 or 10 is normal. And no beta, that is Krishna, that's the thing, that you don't give 1, there is no 1, that's why it can never be a odd number. Is it clear? Your BPP score can never be 7, 9, 11, it can never be a odd number, it's always 2 or 0. There's nothing like 1 system. Okay, 1 is not there. Okay, yes, less than 6, beta, you don't even wait till 4. Okay, 8 by 10, 6 by 10 itself is normal. 8 is okay, 10 is okay, but if the score is 6 and lesser, better to induce the labor and get the baby out. And just for your reference, all this NST is done using NST machine. The remaining components are done with the help of ultrasonography. On the ultrasonography screen, we see whether the baby has a tone, flexion, extension, baby is having movements or not, whether the diaphragm is moving or not, and Liker pockets. Okay, so many students do not know this, that how are the other things determined. So 2, 3 components number 2, 3, 4, 5 is done. You are supposed to do, anybody, we are supposed to do ultrasonography for 30 minutes. Okay, please pay attention. When we have to do BPP, when I want to do BPP, we do ultrasonography for totally 30 minutes. And within 30 minutes, all this 1, 2, 3, 4 components number 2, 3, 4, 5 you check. Okay, and NST is done separately. And very good, somebody already answered in the chat box. Just for your reference, anybody, what is modified BPP? Modified BPP is just to save time because it is quicker. You don't need to waste the entire 50 minutes because sir, NST takes 20 minutes, all of you know. So to do a proper BPP, it takes 50 minutes time. So modified BPP is just 2 things. You do NST and along with it, you do amniotic fluid index, AFI. This was again one of the MCQ few years back. Yes, NST and AFI is called as modified BPP. Is this understood to all of you? So this is very, very important. Okay, moving on to the next question. Yes, a relatively easy question, all of you should answer. We have a patient who is 26 weeks, anencephaly, and AFI is 26. So AFI is normal or more. So what is AFI? AFI is 4 quadrants. So all of you just look on the board. If this is the baby, if this is the baby, what we do in AFI, we put the ultrasonography probe on the maternal left upper, left lower, right upper, right lower, and in each quadrant, please understand, fluid appears black on sonography. Okay, so in each quadrant, what we measure the deepest vertical pocket. Is this understood to all of you? We have to measure the deepest and I have to measure the vertical pocket. We can't measure this pocket. This is wrong because this is a horizontal area. No, you have to measure the deepest vertical pocket. And what do we do? In centimeters. Okay, so this is just an example, all of you. Suppose here we get a pocket of 4 centimeter. Here I get a pocket of 3 centimeter. Here we again get a pocket of 3 centimeter, and suppose here I get a pocket of 5 centimeter. What do we do? What do we do? What is it? We have to add all 4 of them. So 4 and 3 7, 7 and 3 10, 10 and 5 15. This patient's AFI is 15 centimeter. Is this understood to all of you? This is just an example. Yes, all 4 quadrant addition, and as per this criteria, when the AFI is more than or equal to 25 centimeter, it is poly, and when it is less than 5 centimeter, it is oligo. Yes, so in this question, since the AFI is 26, we are having a patient of polyhydramnios, which is of course expected in anencephaly. So they are asking you the mechanism. All of the following are responsible for increased Leica volume except anybody, except, okay, no, option 2, okay, no, 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 okay, simple M's. Chalo, anyone else? All of you quickly. So what are the causes of poly in anencephaly patient? Nobody? A, B, C, D. 1, 2, 3, 4. Yes, very good. Vishal Parmar 4. Rameshwar Nayak 4, 4, 4. Yes. Okay, the shoe not 3, 3. Okay. Yes. So please pay excellent, all of you. Excellent. So please pay attention that anencephaly is a open neural tube defect. Do you agree with me or not? It's a open neural tube defect. So what is going to happen? CSF is entering the Leica. Please understand, as if this is a neural tube defect, these are the, suppose the meninges. The meninges are exposed to the amniotic chamber. What will happen? Sir, the CSF, yes or no? The CSF is going to leak. Okay, the CSF is going to have transudation and enter into the amniotic cavity. Yes, so the volume of amniotic will increase, of course. Yes, so transudation of CSF hota hai. Now whenever, please pay attention, baby swallows the Leica and baby passes urine. So fetal urine contributes to Leica. So baby passes urine and then the baby swallows the same thing. So whenever the swallowing is going to be defective, Leica will be more. So all the swallowing, like esophageal atresia, duodenal atresia, diaphragm, so all the swallowing defects, and there is absence of swallowing also in anencephaly. Okay, and in anencephaly, the pituitary gland is absent. So if the pituitary gland is absent, what is going to happen? Base anybody? If pituitary gland is absent, what will happen? Absence of ADH. What is ADH? Antidiuretic hormone. Antidiuretic hormone, if it is absent, because pituitary is not there, there will be more diuresis and baby will pass more urine. Increase urine output of the baby. Do you agree with me or not? And I told you fetal urine contributes to Leica. So there's going to be absence of fetal pituitary, which causes absence of ADH. There's going to be more diuresis. So urine output will be more, and therefore all these three will cause polyhydramnios. Simple uteroplacental insufficiency is going to cause oligohydramnios. Is this understood to all of you? Because if it's a utero, go back and listen to my class of IUGR and your, what do you call, brain sparing effect, all that. So in uteroplacental insufficiency, what we get oligohydramnios. And very good, Srishti, this anencephaly is also the anomaly which can be detected earliest. Okay, it is the anencephaly is the earliest to diagnose on ultrasonography. Most of the anomalies we diagnose at 18 weeks on sonography, but here when I do the 11 to 12 weeks NT scan, yes, as early as 10 weeks, and definitely by 11 to 12 weeks time we can diagnose this anencephaly on USG. So this is again a very important MCQ, that out of all, they might give you 4 or 5 anomalies: kidney problem, heart problem, liver problem, which is the earliest anomaly to diagnose on ultrasonography? Please mark anencephaly as the answer. And in anencephaly, sir, 1 is there, 2 is there, 3 is there. All these 3 contribute to polyhydramnios. Answer is option number 4, because sir, any patient that has uteroplacental insufficiency, it leads to development of oligohydramnios. Is this understood to all of you? And we'll get time for this one more MCQ also. Primi gravida, 36 weeks of gestation, decreased fetal movements. IUGR is there because it is corresponding to 33 weeks of gestation. And at 33 weeks, what is the most important investigation we do on IUGR? Color Doppler. Okay, color Doppler we discuss in detail in the actual classes. Please pay attention. Color Doppler is done, which is showing reversal of flow, which is the most appropriate management for this patient. Yes, very good. Abhi, Rajdeep Saha, Shrishti, excellent all of you. So please pay attention that on color Doppler we come to know the blood supply to the baby, and color Doppler, all of you note down, is the most important investigation. If somebody asks you, the whole management of IUGR is based on color Doppler. The most important investigation in management of IUGR, if somebody asks you, what is your answer? Your answer will be color Doppler. We are basically interested in studying the umbilical artery Doppler. Okay, in color Doppler I study the umbilical artery Doppler, and there's going to be S by D ratio, elevation, all that, and basically the diastole keeps on becoming less, and initially, please pay attention, first there is absent flow. Absent flow itself is very, very bad. It tells you there is impending death, and then there is reversal. Please pay attention here. So if there is already reversal of flow, can anybody tell me in 2 words, what does reversal of flow in umbilical artery indicate? Basically this situation. Why is the answer option number 4? All of you told me option number 4 is correct, and we have to do the delivery of the patient. Otherwise, what will happen? Anybody? So please pay attention. Reversal of flow, it is telling you impending IUFD. That is your diagnosis. Are all of you understanding that, sir, this patient who is having reversal of flow in the umbilical artery Doppler, it is telling you impending IUFD. Now anytime the baby can die. Therefore you don't induce the labor at 38 weeks. No, we are only 36 weeks. It is telling you to wait for 2 weeks. Sorry, there will be IUFD by that time. Yes, baby will die. Similarly, you give steroids if the baby was 32, 33 weeks, you give steroid, but then don't wait for 7 days more. No, at your absent flow, and if we had been 32 weeks, you might want to give steroid and just wait for some time, but again it's very, very dangerous, and you don't monitor till it becomes absent diastolic flow. No, that is already happened, because first there is absent flow. Please understand this. How is the sequence of event? Sir, in the umbilical artery, absent flow happens, and then there is reversal of flow. Both these are very, very dangerous. Absent flow is also indicating impending IUFD, and reversal of flow to definitely indicating IUFD. Okay, the IUFD, impending IUFD. So absent flow, at the most you may think of waiting for 1 or 2 days, but again absent flow also you have to immediately plan and reversal. And by the way, just for your reference, both these absent flow and reversal of flow are indications of doing immediate LSCS. How will I plan the termination? Please understand, these babies are small, IUGR. They will not be able to bear the stress of labor. Is it clear? They are not able to bear the stress of labor, because labor is a tough journey. While passing through the birth canal, they may have distress and complication. So better, in ideal scenario, when there is absent flow and reversal of flow, of course good NICU is required. Baby will be in NICU, but you do LSCS is better. Get the baby out without giving stress to the baby. So rather than Christina, after giving steroids, we want to at least delay the delivery by 24 to 48 hours, 48 hours. Okay, but that is the case if when do I give steroids, and that had the patient been 30 to 34 weeks. Okay, 36 weeks pe steroids are not so much required. Had the patient been say 30 to 33 weeks and we would have been only elevated S by D ratio, then I can give steroids and wait. At the S by D ratio, once it's elevated, that time you can still wait. Okay, but once it is absent flow, there is no point waiting. Yes, only case if it's absent flow and we are still 30 to 33 weeks, then we might wait for 48 hours, because they say that after absent flow, within 4 to 5 days the baby can die, and reversal of flow within 48 hours the baby will die. So you basically never wait. Absent flow itself you deliver. Steroids you should have given earlier, and at 36 weeks there is really no point of giving steroids. Okay, and after steroids anyway you don't wait for 7 days time. Is it clear? And specifically reversal of flow you don't wait only. Is this understood to all of you? Yes. Okay, so basically remember that in IUGR, whether it's symmetric IUGR or symmetric IUGR, this is the umbilical artery Doppler. Maternal uterine artery Doppler is used for prediction. Anybody? So this is all the umbilical artery Doppler which we do when there is IUGR. What we first study, we study the S by D ratio, systolic to diastolic ratio we study. Okay, systolic to diastolic. Remember one thing, higher the D, good for the baby. Okay, higher the D, good for the baby. So the D, when the problem of IUGR starts, the D begins to decrease. So if the D begins to decrease, the ratio begins to increase. Okay, ratio begins to increase, which is one of the earliest changes to happen. Okay, and then there's absent flow, and then there's going to be reversal of flow. Yes, and what another point we have to remember is that the uterine artery Doppler, yes, maternal uterine artery Doppler of the mother, we do, it is used as a predictor. Anybody? Predictor for what? If maternal uterine artery Doppler I do at 16 to 18 weeks of gestation, and if we see a diastolic notch in the maternal uterine artery, it is a predictor of preeclampsia and IUGR. That this patient, आगे चल के, we are 16 to 18 weeks, this mother in the future will develop preeclampsia, and the baby may develop IUGR. Is it clear to all of you? So maternal uterine artery Doppler, please pay attention all of you. Maternal uterine artery Doppler is for prediction. It is for prediction of preeclampsia and IUGR. That is done at around say 18 weeks, 16 to 18 weeks. And then when actually IUGR is suspected, once there is IUGR happening, then you have to directly study the baby ka umbilical artery Doppler. Is this understood to all of you? So different indications, we should know which vessels to study as per this. Okay, so I hope all of you had a great time today. These are some of the very, very important MCQs which we discussed for the upcoming NEET PG as well as FMG examination. And all of you, last chance today, get in the code MENTOR, MENTOR, and this is an extra discount of 10% extra, so total 20% discount, and depending on your requirement, 6 months, 12 months, 18 months, 9 months subscription are also available. So MENTOR is the code available, and hope to see you soon in all the future classes. I hope this was very informative session. Bye bye, best of luck. Thank you very much for coming in today, and see you in the upcoming classes. Bye bye, thank you very much.